to Rishi Singhal from the United Kingdom. He's a consultant bariatric surgeon at Birmingham Heartlands Hospital. And also, he's a senior lecturer at the University of Birmingham. He's also the medical director of the Healthier Weight Group. And he's going to give us a talk about the amount of weight regain after bariatric surgery helps predict health risks. Rishi.
Thank you for that introduction, Harris, and thank you for introducing me. I would like to start by thanking Ezisurg, Josie, and Hila for actually picking up a topic that is so interesting. I've been to a lot of conferences, as all of us have been, but usually we have the same old presentations: a sleeve better or a bypass better, and what does a sleeve do at 2 years and what does a bypass do at 2 years. But this is one of the topics that surgeons don't really discuss. That does weight regain happen, and many of the younger surgeons don't even accept that there's weight regain after bariatric surgery. And more importantly, how does weight regain affect your health? Now, this was a topic that I did not know really anything about. So I confirmed with Ezisurg a few times that this is what you want me to talk about, and I actually had to spend some time reading about it to understand what this topic is so that I can do some justice. So as Harris said, my name is Rishi Singhal. I'm a consultant bariatric surgeon. I'm a senior lecturer, and I'm the medical director of one of the largest private bariatric companies in the UK. I'm also quite interested in academia, which is why I'm here today with you guys. Now, any presentation on bariatric surgery cannot start without this slide, and this is one of the slides I like because it puts things into perspective of what the problem is. And almost 1.4 billion adults are overweight or obese. That is a lot. That's more than the population of India. That's just slightly less than the population of China, and that is 1/5 of the population of the world is overweight or obese. So that is what the problem is. That is what we're talking about here. That is the number of obese individuals. Now, how many operations are being performed worldwide? Well, this is very different to understand. And why am I discussing this in such a topic? I'll come to that in a moment. But the IFSO global registry suggested that 300,000 operations had been performed from a total of 51 countries, 5 continents, approximately 220,000 from 5 years, giving us an average of 50,000 a year. Now, I don't think that is the real number. Many of the other publications have estimated that this number can be closer to almost 500,000. So we think anywhere between 250,000 to 500,000 bariatric procedures are performed worldwide. And that seems sort of logical. I know the UK numbers, and UK numbers are sitting at around 20,000. I mean, 5,000 in the NHS, 15,000 in the private sector. So they sit at around 20,000. So that is 1/25th or 25th of the world's load. So I think that's more or less right. 500,000 procedures is just right. Now, this number is again reinforced if we look at the Geneva Study. Now, Geneva Study had nothing to do with today's topic, but Geneva Study was an international registry performed by us. And one thing it gave us was how many procedures were performed worldwide. Now, even during the pandemic, in 6 months, 7,000 operations had been performed. So overall yearly volume is at least 20,000 and can be up to 500,000. That's what we think the overall yearly volume is. But this is why I have been leading up to this point. The Geneva Study suggested that 5 to 6% of all operations performed worldwide are revisional procedures. And this is why I was giving you all this background to understand how much revisional surgery we do. Why is this important? Well, revisional bariatric surgery has only a few indications. And one of the most important indications of revisional bariatric surgery is weight regain, followed by inadequate weight loss, which can be almost lumped together, followed by non-resolution or recurrence of comorbidities, and the last one is complications. So a huge proportion, and almost 90% of revisional procedures are performed, I do, for weight regain. Thus, we know just by looking at indirect facts that weight regain and recurrence of comorbidities with bariatric surgery is associated. So that is one thing that we all agree on first. So let's understand about weight regain, how much weight regain is happening. Well, I could not find a lot of literature. As I said, this was a difficult topic, and I wasn't even sure if that's what I was required to do. But when you do a literature search, there is only one systematic literature review looking at weight regain, which is worth talking about. This literature review was from Pittsburgh, just published last year, so it's quite contemporary. 15 studies were included, mainly Roux-en-Y gastric bypass and some sleeve gastrectomies. And what this study found that even for a Roux-en-Y gastric bypass, the weight regain can be anywhere between 8% to 19% of the maximum weight loss. So the weight regain after Roux-en-Y gastric bypass, which most of us would agree in some way or the other, is the gold standard bariatric procedure as far as weight loss and maintenance of weight loss is concerned. One of 25% of procedures in the world are Roux-en-Y gastric bypass. 8 to 19% of the maximum weight loss can be regained after Roux-en-Y gastric bypass. So that's interesting. That's what this says. So then, once we establish that weight regain is happening after most procedures, I think the important point that we need to discuss is why is weight regain happening and can be predicted somehow. So first, let's understand the psychological aspects of weight regain. Now, there was again only one systematic review in the entire literature looking at weight regain and the psychology or the psychiatric aspects of it. One of the studies assessed impulsivity, and another study reported the health-related quality of life. And what they found was the health-related quality of life was negatively associated with weight regain, and they measured quality of life through Moorhead Adult Life Questionnaire. So what does that mean? That if there is weight regain, the quality of life goes down. So weight regain, that means has some consequences. Weight regain is not just a pure number, it is having a psychological morbidity already. The quality of life is getting worse. So it thus means this is something very important that we need to understand and discuss further. So psychopathology played an important part in weight regain, and psychological health was affected negatively or adversely due to weight regain. That is more or less the précis about psychology and the literature. Now, this was a very interesting study which looked at the various factors that are affecting weight regain 10 years after a Roux-en-Y gastric bypass in just over 200 patients. They looked at many factors, and one of those factors was BMI. Now, this is very, very interesting, actually very interesting. This graph just shows that everybody regains weight over a period of time, in which you've already established that weight regain does happen. But let me walk you through this slide, and it took me a while to understand this, it took me a while to understand it, trying to interpret it, and I hope I can do the same for you. Now, the middle set of column is for the, if you're watching the screen, on your left hand is all patients. The middle column is patients with a BMI less than 50, and the rightmost column is patients with BMI more than 50. Now, if you look at the first yellow row, which is the third row down, looking at percentage excess weight loss. Percentage excess weight loss with a patient of BMI less than 50 at 5 years is 60%, dropping down to 55%. So that means obviously weight is being regained. The same excess percent weight loss for a patient over 50 BMI was lower, and we know that. We know if you are heavier, the weight loss is lower, and as a result, many surgeons and a lot of the literature would say that if you operate on somebody over 50 or 60 or 70 BMI, consider doing a bypass instead of a sleeve because they have better weight loss, because you want more weight loss in these patients. But if you look at the sixth row down, which says percentage weight regain, the weight regain in BMI less than 50 at 10 years is 32% as compared to 20% in the BMI over 50. Now, the authors did not conclude on it or did not talk much about it, but what this means is that although the weight loss is lower in patients with a BMI of more than 50, it seems their weight regain is lower as well. So they lose less weight to start with, but then they regain less weight as well, percentage-wise, not absolute. Percentage-wise, they regain less weight. So that's quite interesting. So if you're heavier and you have bariatric surgery, yes, you may not get a good result or as good a result, but you won't gain as much weight as everybody else below 50 BMI. That's quite important. But what else this study showed was that the weight regain can be up to 15% between 2 and 10 years and is seen in 2/3 of the patients. So I think this is why I really liked this topic. I had to read a lot about it, and this is data that you can actually use to consent patients, to explain to them that actually weight regain is going to happen. There are systematic reviews that are published that weight regain will happen no matter what the operation, and it could be up to 60%. And if you're over 50 BMI, your weight regain may be less. Now we know that weight regain happens. We know that BMI can affect weight regain. Now the question is, can we predict the success of bariatric surgery? Okay. Now, this is again a very, very, very interesting study. It looked at over 200 patients, 5 years follow-up. And what did this study find? Patients who had comorbidities at 5 years after surgery had a greater weight regain compared to individuals without them. Now, that is quite interesting. The corollary of this would be patients who have a higher comorbidity burden when they started are going to regain more weight. Because the patients who had more comorbidities to start with will have more comorbidities at 5 years as well. So patients with more comorbidities had a greater weight regain. They looked at recurrence of diabetes. They felt that recurrence of diabetes may be related to weight regain, but they did not know whether that happens due to weight regain itself, so the kilograms gained, or due to increased calorie intake. So data shows that there is recurrence of diabetes. But is this due to the kgs gained, or is this due to increased calorie intake, which happens with pouch dilatation and maladaptive eating behavior? So we know that. But the very interesting thing they said was that it is important to maintain a weight of around 30 kilogram per meter square, 30 BMI. Why is that? Anybody with a weight of less than 30 BMI are less likely to regain weight, and anybody with a BMI of more than 30 BMI are more likely to regain weight. Now that is again very interesting. So we have to ask our patients to maintain a lower weight after surgery. If they maintain a higher weight, they are more likely to gain weight. So it is the same thing that you talk about the Poiseuille's formula for the lungs, that if the lungs are fully inflated, they are, well, it doesn't work here. I had a thought running through, so I thought I'll go through it. So the lower the weight loss that is maintained, the less the chance of regaining weight after the operation. So let's come to the SOS study, and there is, and this is probably the last piece of literature that I'm presenting. This was again published only last year, and no study in the world can be concluded without talking about the SOS study. And when they analyzed the SOS study, what did they find? Now, those of you, I'm sure all of us know the SOS study, but for some of our juniors and budding surgeons and metabolic physiologists, physicians, SOS study was a case control study of 4,000 patients. They followed up for 20 years or so. 2,000 of those patients had bariatric surgery, 2,000 did not have bariatric surgery, and they looked at various outcomes: diabetes outcomes, long-term mortality, cardiovascular mortality, microvascular complications of diabetes. They looked at all kinds of time points along with weight regain. So when they analyzed the SOS trial data, they found that 50% of patients obtaining remission of type 2 diabetes at 2 years follow-up presented with a relapse at 10-year follow-up. So that's very, 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 very interesting. Now, this is very different from randomized control trial data where patients are being provided with expert help and everything. This was a community-based follow-up program. This was not a controlled study. This was just a cohort follow-up study, SOS trial. So everybody who had remission of diabetes at 2 years, half of them did not have remission at 10 years. They looked at Stampede trial, and what they found was the proportion of patients achieving type 2 diabetes remissions reduced from almost 80% to 45% in the 5th year for Roux-en-Y, and 51% to 25% for falling asleep. So again, type 2 diabetes remission is reducing. And they found that percentage weight loss is the most important factor determining diabetes remission between the two procedures. So now we have another piece of data that we know, that half of the patients who have diabetes resolution will have diabetes again at 10 years, and weight loss is the most important factor deciding diabetes remission. So if you want to do a bariatric procedure on a patient, it is probably better, based on literature only, not my personal opinion, to do a bypass as compared to a sleeve, because you're likely to have more weight loss. If you have more weight loss, you have more diabetes remission if those patients have diabetes. So I know this was a whirlwind of a talk, and with a lot of literature discussed. I have tried sticking to only the important pieces of literature that I would want to form my opinion on. So what is my opinion at the end of this study? or this presentation, which actually I read as well. So I've learned, along with all the audience and my friends, that up to 20% of the maximum weight loss is regained. So it is important for our patients to know that whatever weight you lose, you will regain 20% of it, or you could end up regaining 20% of it. It is important for us to tell them that patients who have comorbidities will have more weight regain. That's very important. We need to tell them that if you do get remission of diabetes at 2 years, there's a 50% chance that you won't have remission at 10 years. The ones who don't get remission of diabetes at 2 years are more likely to regain weight anyway, and we've discussed that. Patients who have more comorbidities at 5 years will regain weight. But even the ones who have complete resolution, 50% will not have resolution at 10 years. And it is percentage exacerbate low. So work hard, and maintain follow-up, maintain compliance, because once you've done the operation, that is what is promoting better remission and less weight regain. Once again, I would like to thank Ezisurg, Hila, who I know very well now, Josie, my friends, Harris, and everybody else now on the panel for giving me this opportunity to talk about a topic which I really enjoy. Thank you very much.
Well, thank you so much, Rishi. That was a real expert overview of a very complex topic, a topic which is always evolving. And thankfully, we have actually 15 minutes of questions, not 5. So I have quite a few questions to ask you. And bearing in mind that this is a very high quality event, which I think is going to be viewed by a lot of surgeons throughout the world, experienced as well as junior surgeons. When you have a patient with weight regain in your clinic, what is your protocol about what you do? And is it different for patients in the private sector? Because sometimes what I see is that patients in the NHS are really evaluated quite thoroughly through psychology, dietetic review, endocrine review, exercise, compliance with exercise. Whereas in the private sector, there seems to be a trigger finger for doing another operation for financial reasons. And I just wanted to firstly know, what is your protocol in your clinic? And do you see any difference in how patients are managed between public and private?
That's an excellent question. And I'm not just saying it because I think you have asked me a question which I wouldn't want to be asked, but you've asked it, so I have to answer it now. Firstly, let's start with the differences. There is a difference in the NHS and the private sector. In the NHS, not a lot of patients present with weight regain themselves. You pick up their weight regain. Their engagement with their own self, with their own weight, is not as much as I see in the private sector. Yeah, I do see it, but it is not as much. And the private patients are really quite conscious about their weight regain. So what do I do in the, let's start with what do I do in the private sector? Well, I am quite lucky in some ways in the private sector that I work with a very large company. We have 15 full-time dietitians. We have a psychologist. We have 2 full-time endocrinologists who work in the private sector with us full-time. So every patient who, and we have a radiologist, every patient who presents with weight regain undergoes full evaluation by a dietitian, a psychologist, and a radiologist. So we understand what the pouch is. There's no point flogging a dead horse. If your sleeve is this wide and you have a huge redundant fundus, there's no point beating you up with a dietitian and a psychologist. It's not going to work. So we'll have a full radiological evaluation. If radiologically it seems to be decent, then we'll have an evaluation with the dietitian and psychologist. My aim always is, at least in the first 5 years, that I can manage the patients without any surgical interventions. Now that also depends on what surgery you're presenting with. If you're presenting with a band, we know that band has come into disrepute, and no matter how hard you try, sooner or later you will have to take it out. So with the band, I'm a bit more liberal in converting it to a bypass, and you know that I've now done over 200, 250 band to bypasses in the private sector in the UK. So with the band, I'm a bit more liberal. When I find a sleeve, I try teaching them the right thing with the psychologist, with the dietitian, and see if it will work out. With the prior bypass, I insist on giving them a period of 1 to 2 years when I can try managing them conservatively. But this is all multidisciplinary. At the same time, we also have a medical weight management arm. Now, in the NHS, Saxenda is not funded for weight regain. Liraglutide once a day is not funded. But in the private sector, I have a system to prescribe Saxenda. And now I also have a system to prescribe semaglutide. So I'm giving semaglutide once weekly to my patients with weight regain and see what happens. If they're happy enough with that, then I try avoiding surgery and provide them psychological support with dietetic support, assuming their radiology is okay. If radiology is bad, I think you have to do something about it. If it's a band, then I usually end up doing something about it. If it's a sleeve, we give them some time. If it's a bypass, I give them 2 years or so at least and see if I can change them. And then what kind of revisional procedure will you do depends really after that. So this is my algorithm. And I must say that I feel that now I have more resources in the private sector than the NHS. The NHS, for me to find a psychologist and have some time, it takes me 6 months at the moment, currently. Now, I'm not dissing the NHS in any way, but that is how the system is. It is not geared up for complex work. The dietitians are available, radiology is available, but the psychology availability is not there. And even if that is there, closed follow-up is not there. Closed MDT-based follow-up is not there. So managing patients with weight regain and managing them without surgery, I find actually is quite difficult in the NHS as compared to the private sector. So 30% of patients I'll salvage, 70% have a reoperation.
Great. Well, thank you for such a thorough answer to that difficult question. The other question I have is that I know sleeve gastrectomy is the commonest operation in the world. I must say I do 90% gastric bypass revision and only 10% sleeve gastrectomy, mainly in very, very high BMI patients or very complex patients with hostile abdomens. Do you think there should be, in terms of looking at the weight regain head-to-head, sleeve versus Roux-en-Y bypass, it's pretty clear that the weight regain with sleeve gastrectomy is higher. What do you foresee as the next 15 years in terms of what type of revisions we're gonna be doing? Because as you mentioned, bands, many of them are having to be removed because of complications or poor weight loss and are being converted to usually bypass. What do you think is going to happen with this sleeve population? Because as you say, some sleeves are not really sleeves. They're just like side swipe of the greater omentum, not greater curvature, not really done well. Where do you see sleeve in the next 10 years?
I like the sleeve. So my 40% of my personal volume is sleeve. I'm sorry, 60% is bypasses and one anastomosis bypass. So I like the sleeve. I think it's a very good procedure for quality of life. You can't compare the quality of life with a sleeve to a bypass. With a bypass, you can have chronic abdominal pains, you can have diarrhea, you can have all those kind of dumping, all those kind of problems that you don't have with the sleeve. But then sleeve has a slightly higher weight regain as compared to a bypass, as you rightly said. A lot of the sleeves will have to be revised. Re-sleeve, as you know, is not really an option, and more the literature would say that re-sleeve doesn't have good outcomes, and it's not something that I'm doing now. Most of my sleeves, although I used to revise them to Roux-en-Y, I revise them to one anastomosis bypass and only a Roux-en-Y when they have reflux, severe reflux. Similarly for bands, if they have severe reflux with a deflated band, I do a Roux-en-Y, and if they don't have any reflux with a deflated band, I do one anastomosis. I don't revise bands to sleeves. I think 80% of the sleeves will be revised eventually. 20% of the sleeves will be revised eventually. 80% will stay as they are. That's not because they did not have weight regain, but that's because the patients are happy with what they have at the moment. I think we have to understand that you and I may decide that this is using Reinhold criteria, that this is a failure of bariatric surgery, but that patient may disagree with you. That patient may turn around and say that, Dr. Khwaja, I had bariatric surgery to get pregnant because I had infertility due to PCOS. I'm now pregnant, I have twins, and even though I have regained 50% of my weight, I'm not a failure. I got what I wanted from bariatric surgery. So it doesn't matter what we believe. So as a result, I don't think 80% of patients will ever have a revision. It's only 20% who either have the financial capacity, the mental capacity, or the want to have a redo procedure. Because we know that redo procedures have a much higher complication rate. And their weight loss is lower and their weight regain is even higher. So I looked at even revision surgery. Weight regain is even higher, and I've looked at my own data.
Great. So excellent. That's such a very intelligent answer, and thank you for that. We have 5 more minutes for questions. Dr. Shalan, would you like to ask Dr. Singhal a question?
Hello, everybody. Thank you very much, Doctor, for your presentation. And just one point to add regarding what kind of procedure you may choose primarily for the patient. And many of the doctors may go straight forward to applying the rules of the guidelines in the book about a patient without asking the patient himself, or even digging deep into the patient quality of life, what he looks for, what he's capable for. Like, for example, if a real, in our country, for example, if a patient has collected all the money he has and to do the surgery, and he is not capable to go any through any kind of medications for life or complications whatsoever, and then some of the doctor will choose a bypass for him. After 2 or 3 years, you'll find him no health. Yes, he lost a lot of his weight, but he is anemic, he hypovitaminosis, hypoproteinemia, and he is always going to the hospital. So a patient who is smoking and he is not willing to give up smoking, and then you choose a bypass for him, and he comes with a marginal ulcer, with frequent attacks of hematemesis, with melena, so I think it's the surgeon rule, even if the bypass is the most suitable surgery for this patient, when the indices or when his parameter is written down on a piece of paper, but still this surgery of choice does not match him when you consider his socioeconomic mental status. And then even if he is asking for a bypass, you may redirect him to sleeve, I'm doing this myself. And if he insists on a bypass, I then get one step backwards, because if you do bypass, then you will come after 2 years asking me to revert it. I think this would be also important point to consider. What do you think?
I couldn't agree more. I think because of the limited time we have, we did not go into the full decision-making process, but psychology, their personal understanding of the procedure, their compliance. So if we know that somebody is not going to have compliance, we will not do a SADI ever, or we will not do a BPD or a DS, or even a very aggressive mini bypass or one anastomosis bypass. Somebody who's living up in the mountains, who cannot travel to the main city within 6 hours, I will not even do a Roux-en-Y gastric bypass in the fear of internal hernias. So I think you are absolutely right. We need to tailor-make the procedure to the patient. Luckily, because of practicing in UK, I have patients who are close by, and most of them are engaged and they understand. But I think we have to go with what the patient wants eventually. It's a discussion. And if a sleeve is the best option in the circumstances, then I think we should do it. I think there are only 2 mainstream procedures, as the Geneva study shows. Sleeve, which is 70% in, or 60% in the world, 25% is Roux-en-Y, 10% is one anastomosis. This was the latest data from Geneva. 60% sleeve, 25% Roux, 10% one, and the rest is just any other procedure. So sleeve and Roux continue to be the commonest procedures, and they continue to be the commonest revisional procedures as well. So band will either be revised to a Roux or a sleeve, and a sleeve will either be revised to a Roux or a one anastomosis usually. So I think these are the commonest procedures, and I completely agree with you that you have to take the patient at the center of the whole picture and tailor-make to the patient's needs.
Excellent. That was a very thorough answer to that question. We have 1 minute left for questions. Quick question, Rishi. A lot of programs in the United States I'm seeing are employing an exercise practitioner, which seems like a real, amazing benefit to have in a hospital. Someone who can not only encourage weight loss or maintenance weight loss through encouraging patients to do exercise, but making sure that they build it into their lifestyle. Which for me seems a very logical thing, because when I do these Roux-en-Y cases and I look at how small the pouch is compared to the rest of the stomach, the remnant, and I think, well, if this patient gains weight in 10 years, it's not the operation usually, because I do a circular staple gastrojejunal anastomosis, which gives me a 16 millimeter internal anastomosis. The pouch is very standardized, and my limb lengths are all measured with a calibrated Johann. And so what's your view about that kind of that kind of part of the management? Because I really think that we are very keen to keep on operating, making things smaller.
Again, very intriguing question, and I will have to share my unpublished data with you then. I also have an app, a proprietary app for my company, whereby I provide you access to a physical therapist and an exercise consultant. And what we have found in our data of over 2,000 patients' data, that if patients who use the app more than 8 times a week have 3% excess weight loss more than patients who do not use the app.
Very interesting.
We already have data on this. This is private healthcare data from our private app. So patients who access the app have more weight loss. And the app mainly has dietetic recipes and physical exercise activities. So it has yoga classes on the app, physical activities on the app. It has everything on the app.
I mean, that's really, it would be really useful to have that published. And the reason I asked the question is that the American Physical Fitness Association, they recommend at least 150 minutes of exercise per week. That's not in bariatric patients, that's in all of us. Yes. And so I think that's what we should be encouraging patients as a minimum once they've recovered from the surgery, perhaps after 6 to 8 weeks when things have healed up, that they should partake in 20 to 30 minutes of exercise 5 days a week, mainly cardio and getting that heart rate above 120, because some patients' ideas of what exercise is are very different, perhaps, to what we consider exercise. Some would consider taking the dog for a walk as exercise. I wouldn't. And so I think I really write that in all my clinic letters after when I follow up patients, that this patient is actually doing this. And I must say, since I've been doing that for the last 6-7 years, the Roux-en-Y patients are getting between, on average, after 2 to 3 years, between BMI 25 to 30. So I do think if you encourage patients to take responsibility, that they've done, that the surgeon has done his part and the whole MDT. But ultimately, as you know, in a lot of public health systems, patients after 2 years are discharged back to the primary care doctor to follow up, because we can't offer lifelong follow-up in public hospitals, certainly in the UK. We need to give patients knowledge as to what they should look out for and how they should adapt their lifestyle. And I think that's really, really important, wherever the patient is in the world, to ask them to take responsibility, because ultimately they're going to be the best kind of guardian of their own operation and their outcome. If they stick to the rules, don't smoke, don't drink alcohol heavily, don't take NSAIDs, attend their follow-up, call for help if they get abdominal pain, especially after a bypass. All those things are really important. Andrei, do you have any questions for Dr. Singhal? We actually have a few more minutes.
Yeah, thank you very much for the outstanding speech. And I'm not the bariatric surgeon, but I have one question. I know in our clinic, the common procedure for the patient is the bypass with the one anastomosis. So my question is, what is the place for this surgery? What kind of patient we should to choose for this procedure? Thank you.
Lovely question, Andrew. So I'll just reflect on my practice and that will give you the answer. If I look at my only primary practice, I've spoken to you about my revisional practice. So 50 to 60% of my work is revisional now. I only do revisional surgery in the private sector. But let's look at my primary practice. My primary practice was sleeves in almost all patients less than 50 BMI who did not have comorbidities. Over 50 BMI, I almost did Roux-en-Ys 5-7 years ago. And in anybody less than 50 BMI with comorbidities or reflux, I did a Roux-en-Y. Now what has happened is I still do the sleeves in the patients I was doing. In anybody without reflux and over 50 BMI, I do a one anastomosis. And only patients with reflux get a Roux-en-Y. So in primary surgery, the only indication for a Roux-en-Y is reflux for me. Everybody less than 50 without comorbidity gets a sleeve. Everybody with comorbidities or over 50 gets a one anastomosis, full stop. That is more or less what I'm doing. So the only indication for a Roux-en-Y in my current practice is either reflux or revisional surgery after a sleeve or a band with reflux. So reflux is the only indication for Roux-en-Y, full stop, in my practice.
Thank you very much.
Great. Well, thank you, Rishi, for that really impressive talk and answers to these very difficult questions. We're going to move on to our next esteemed speaker, Mr. Ivaylo Zvetkov, who's a consultant bariatric surgeon from the James Cook University Hospital in Middlesbrough, United Kingdom. He's going to speak to us about the management of weight regain after sleeve gastrectomy and Roux-en-Y gastric bypass. So a real hot topic. And thank you, Ivaylo, for taking part in this event. Very, very grateful. You just need to unmute, Ivaylo. Can you hear me, Ivaylo? You just need to unmute. Unmute. Yes, I can hear you now, Ivaylo. If you wouldn't mind starting from the beginning. You just need to unmute yourself. You're on mute, yes.
Just a few seconds. I want to see why the slides are not going up and down. A few seconds. Yeah. So thank you very much for the possibility to have a presentation invited on this webinar by Ezisurg and Mr. Paja about management of weight regain after sleeve gastrectomy and Roux-en-Y gastric bypass. According to the Global Nutrition Report, about 38.9 million of children are overweight or have a morbid obesity, and 2.2 billion adults, over 40% of all men and women, are overweight and obese. According to the current diets, there is a direct impact on the health of our planet, and we see that even North American diets have the greatest environmental impact, while African Asian diets have the least, but neither are environmentally sustainable. Bariatric surgery is currently the most efficient and durable intervention for severe obesity. Unfortunately, 20 to 25% of the patients struggle with considerable weight regain after bariatric surgery. And weight regain after bariatric surgery is emerging as a common clinical problem due to the increase of the number of the procedures. And also it should be intervention on time due to the curtail the potential recurrence of comorbidity conditions. According to the literature review, there is a distinction between the two types of weight loss failure post-bariatric surgery. One is the insufficient weight loss and the weight regain. The grouping of these two definitions should be discouraged because insufficient weight loss is defined as excess weight loss of less than 50% at 18 months after bariatric surgery, while weight regain is defined as regain of the weight that occurs after achievement of initial successful weight loss more than 50%. There are different several definitions about the weight regain, which are including the BMI, excessive weight loss more than 10 kg from nadir, any weight regain, or weight regain after diabetes type 2 remission. There are several causes about weight regain after bariatric surgery, and these are multifactorial and can be categorized by patient and surgical specific causes. And despite the successful weight loss after bariatric surgery, in a long-term basis, most bariatric procedures, there can be a weight regain in 20 to 30% of the patients, either failing to reach their target weight goals or failing to maintain the achieved weight loss. There are several mechanisms which contribute to the weight regain, and these are hormonal mechanisms, nutritional not adherence, physical inactivity, mental health causes, and maladaptive eating. Surgical mechanisms are also implicated in weight regain, including enlargement of the gastric pouch, stomach dilatation, candy cane, small biliary limb, or gastrogastric fistula. And as it was mentioned by my colleague from Birmingham, the BMI before the surgery, if it's less than 50 or more than 50, also have a significant impact on the weight regain within 12 months after surgery. Which are the predictors of weight regain after Roux-en-Y gastric bypass? The most predictors, these are the weight of the patient, second is his sex and age and BMI, and also the total weight loss during the year 1 and weight change during year 2. It is found that the total weight loss during year 1 was the strongest predictor of surgical treatment failure. Similar to initial 6 months weight loss predicts the 24 months weight loss also. Of course, the DRM score can predict what will be the remission and relapse of the diabetes type 2 after bariatric surgery. According to the literature review, about 20% of the patients after Roux-en-Y gastric bypass and sleeve gastrectomy can have a weight regain and relapse of the diabetes, which is 18.9% for gastric bypass and 26.7% about the sleeve gastrectomy. According to the Spanish study, which was published recently, it showed that after 1 year bariatric surgery compared with patients who had a diabetes remission, they can develop late relapse of the diabetes type 2 significantly if we have a higher weight regain in a long-term basis. And also, if we have 2 medications in 10 years' time for diabetes, and they lose initially only 30% of weight in 1 year after surgery, the percentage of the remission relapse of the diabetes can be 28 and 59% with and without significant long-term weight regain in 10 years' time. It is known in the last 10 years that a large proportion of the patients with diabetes type 2 who had initially remission following bariatric surgery had a relapse. And according to the data, we have to measure the weight regain 1 year after the nadir weight rather than from before the surgery. Early surgical interventions and better weight loss outcomes are associated with lower diabetes relapse in the long-term time. Hormonal predictors of the weight regain, it's known that we have higher levels of GLP and gastric inhibitor polypeptide. The patient will have a less weight regain in a long-term basis. And the PYY rodent study showed that post-surgical weight regain was associated with failure to maintain elevated plasma PYY concentrations. Unfortunately, the data about the leptin didn't show any significant changes in the weight regain and weight loss after bariatric surgery and the levels of the leptin. But most important is the post-bariatric hypoglycemia is associated with weight regain. And this is a reactive hypoglycemia that occurs after carbohydrate intake caused by the change in intestinal anatomy. After sleeve gastrectomy and Roux-en-Y gastric bypass, 79.2% of the patients showed 10.8% weight regain at 40 months following surgery, and the odds of more than 10% weight regain found to be significantly more than those with post-bariatric surgery hypoglycemia. The dietary not adherence is another very important predictor of the weight regain after surgery. And grazing is defined as repeated episodes of consumption of small quantities of food over a long period of time, accompanied with feelings of loss of control. And it is more important about weight regain rather than the changes of the eating habits patterns of the patient having larger portion of foods or binges. The lack of the post-bariatric surgery nutritional follow-up is significantly associated with weight regain, where 60% of the patients who had a weight regain never maintained nutritional follow-up, unfortunately. Other weight regain predictors, these are physical inactivity. Swedish study showed that there is no difference in 2 years' time of women who had a Roux-en-Y gastric bypass and control group about their physical activity after surgery. Mental health conditions are also very important in terms of the weight regain on a long-term basis for patients who had a bariatric surgery. Anatomical surgical failure after sleeve gastrectomy, dilatation of the gastric pouch is a great concern. It was measured that normally the gastric pouch should be 120 milliliters post-surgery, but it goes up to 524 millimeters in 5 years' time. Among the Roux-en-Y gastric bypass patients who had underwent upper endoscopy as workup for weight regain, identified dilatation of the GJ junction in 58.9%, and elastic gastric pouch and large gastric pouch in 28.8%, and abnormalities in 12.3% of the patients, and stomach diameter of more than 2 centimeters is independently associated with weight regain. Gastrogastric fistula is known another cause for weight regain after Roux-en-Y gastric bypass. What is the management of weight regain after sleeve gastrectomy and Roux-en-Y gastric bypass? Which is the multidisciplinary approach on a long-term basis, probably for 5 years, assessment, review, and giving advices to the patients after bariatric surgery in order to improve their weight loss and achieve better results about 10 years. Behavioral therapy is also very important about the support of the patient in order to achieve control of the weight loss, and also controlling the environmental settings and stimuli which can trigger eating or sedentary behaviors. A randomized trial showed that patients who had advised by a dietitian every second week for 6 weeks after weight loss surgery, in 12 months' time, it will develop better results and better weight loss rather than the patient who had a standard review and advices about the dietary therapy. In terms of the research that medications and pharmacotherapy, use of topiramate, another medication, pentermine and metformin, patients who had those medications and had a weight regain, they achieved better results in weight loss after bariatric surgery. And of course, the most on the top is the use of metformin or the combination of phentermine without topiramate. Of course, it was mentioned that Saxenda or liraglutide is very successful tool in the management of the weight regain in the last 3 years. And of course, patients are losing more weight and they're tackling the weight regain after bariatric surgery within a year or two after the application of the Saxenda in order to improve the weight loss. Unfortunately, in most of the countries in Europe, including UK, Saxenda is not funded by the health insurance systems or NHS, but hopefully in the next 1 or 2 years, the price will go down and probably will be more achievable for management of weight regain to patients who had a weight loss surgery. Surgical endoscopic management of weight regain. First is about the discussion about the biliary length or size of the gastric pouch, Laplace law, size of the gastrogeneral anastomosis, size and length of the sleeve. At one anastomosis gastric bypass is also contributing factors like reflux and hiatus hernia. Endoscopic management of weight regain is a very successful tool, which is not invasive, but in gaining popularity in the next years, and in the last 4 years is getting more promising results and options. And it was started in Brazil by Professor Neto, and hopefully to get more as a tool for management of weight regain among the bariatric centers in Europe and UK. Pouch resizing has been shown to be a valuable option in the short term for weight loss failure or regain in patients who had undergone laparoscopic Roux-en-Y gastric bypass and have a promising results. But on the next slide, I'll show you that prior to surgical revision, it's important to identify the current anatomy for endoscopic evaluation or upper GI series in order to assess whether surgical revision is feasible, which procedure would be the best indicated. We have a distalization of the biliary limb, one option. Second is option, if you don't have a dilatation or enlargement of the gastric pouch, increase the Roux limb to 200 centimeters and put a band, or probability for put a band, application of the gastric pouch plus 200 centimeters distalization. So we have different options about surgical management on appropriate patients for treatment of the weight regain. Management of the weight regain in patients with a sleeve gastrectomy. On the last Congress of Endoscopic Surgery in Barcelona, there was a very big dispute about implementation and future of the sleeve gastrectomy. I honestly, by myself, am not a very fan of the sleeve gastrectomy, and having the experience from Europe of my colleagues and recent revisional surgery in the last 2 years in UK, I found that more and more patients who get a sleeve gastrectomy probably will need not about 20%, I think about 40 to 50% of the patients who had a sleeve gastrectomy in the past will probably need to have any revisional surgery in the near future. It is due to the findings of Professor Prage about the possibility for Barrett's esophagus. The second is about these motility disorders of the pouch, of the sleeve. And the third issue is the weight regain. So the options are refashioning the sleeve as plus fan application, is refashioning the sleeves plus banding of the sleeve, reverse of the sleeve gastrectomy to study as procedure, reverse the sleeve gastrectomy to one anastomosis pads in patients with weight regain and no reflux, and reverse of the sleeve gastrectomy to real wide bypass is not recommended for weight regain only. And however, there are publications about banding the dural gastric bypass after reversal from the sleeve gastrectomy for weight regain. And thank you very much for the possibility again to have my presentation and view and opinion about the issue for weight regain. Hello, I'm not able to hear you.
Sorry, can you hear me now?
Yes, yes.
Yeah. Thank you, Ivelo, for an excellent overview of a very complex and ever-changing topic. It was really a very thorough presentation, and I appreciate all the effort you put in there. What I wanted to ask you is, firstly, a practical question. I can tell you when I did Roux-en-Y gastric bypass, when I started in 2009, I did really short pouches. It was literally one firing across and 160 and 145 vertically. And what I found when I followed these patients up is that they did very well initially, but then after 2 years, they've started to regain weight. And when I did an upper GI swallow, I noticed that the roux limb had almost become like a neo-stomach. It had become dilated. And I don't know whether that's related to how much the patient is eating. So now what I tend to do is a long, lesser curve-based gastric pouch for my Roux-en-Y, and I don't see that problem. And the weight loss seems, certainly from my follow-up, excellent. So do you have any comments looking at the anatomical factors of how you do the primary surgery for Roux-en-Y with respect to the gastric pouch, what your view is about this?
About the gastric pouch, I always do go 2 centimeters below the OG junction, and then try to use as less as possible cartridges to create the gastric pouch. However, there is a little difference about eating habits, to say, in my practice in UK and my practice as a bariatric surgeon in Bulgaria. I still do some bariatric surgery in Bulgaria. This is the size of the gastrojet anastomosis. I found that in UK, due to the eating habits, and most of my colleagues, because I work in Stoke, I work in James Cook Hospital in Middlesbrough, and now I work in Western Hospital, where we started a bariatric unit. But according to me, it is the size of the gastrojet anastomosis, because my colleagues here in UK, they try to use at least 3 centimeters. Some of them use 45 millimeter stapler to do the anastomosis. And scoping and having the revisional surgery, we found that most of the patients now have a wide gastrojet anastomosis, which is causing early dumping, regain of the weight, and another problems with the weight regain. But yeah, the recommendations of World Congress of Endoscopic Surgery from Barcelona last week are as possible a small gastric pouch.
Sure. Okay. Excellent. Now, the other question I have is, you know, one of the big things in bariatric surgery, more so compared to other surgical specialties, is the lack of standardization. Whether it's your gastric pouch size or your technique for doing the anastomosis. And you made a great point there. The first 170 bypasses I ever did were with a linear stapler. And what I found is that, you know, sometimes it's 2 centimeters, sometimes it's 2.5 centimeters, the anastomosis, based on the measurements on the stapler gun. And then when I went up to Liverpool, I started doing a circular staple technique using the Orville 25 millimeter, 3.8 staple height. That gives you an internal anastomosis size of 16 millimeters, which I think the attraction with that technique is, though it's more expensive, it does give you a standardization. I think with the 21 Orville, the internal diameter size is 12 millimeters, and I think that's what's associated with the higher stricture rate. But with the 25 Orville, you get a 16 millimeter. Most of my friends who use the linear stapler technique, they put it into 2.5 or even 3 centimeters, which to me sounds a bit too big. Do you have any comments about that?
My comment is that I always use a calibrating tube in terms to when I put in the pouch, and then when making the anastomosis, I always try to do no more than 2.5 centimeters, and then closure of the staple line I do on a calibrating tube, which improves and helps to prevent to some extent the weight regain.
Okay, great. And does any of the other expert panelists have any comments about standardization of the gastrojeg anastomosis and which technique you feel gives you the better standardization? Rishi?
Yes, Harris. I think there is differences in techniques in the early perioperative period. So you are absolutely right. If you use Orville, you have good standardization and it's a narrow anastomosis. But I have scoped, one of my colleagues does anastomosis with tuoproline, hand sewn. Oh. And I have scoped those after 2 years and I see the proline thread broken and the anastomosis stretches. I do not think it, I know that Rudy Weiner and one of my colleagues used to work with Rudy Weiner 10 years ago. I know Rudy used to use a wide Riles tube and do an anastomosis hand sewn on top. And despite that, they gained weight. I worked with Basil Amori for a bit, and I saw he used to do small anastomosis hand sewn, and they gained weight. I don't think it matters. I don't. Early post-operative, and there is data to show that early post-operative, the weight loss is better with a tighter anastomosis, but after 2 years, weight loss equalizes. And similarly, as even with sleeve, with calibration, you see early post-operative weight loss is always higher with a narrower sleeve, but over 2 years, 2.5 years, these differences disappear. So I don't think there's a huge difference 5 years after an RYGB, depending on what you do. I think if you did a bad, big anastomosis, yes, that's just rubbish. But if you've done a good anastomosis, they'll all be looking exactly the same. And I revise a lot of bypasses. You have that typical straight trunk appearance. You can't even tell what the stomach is and the small bowel is. It all is one straight line, no matter what anastomosis you've done. It's all stretched up after 5 years.
Ivelo, you wanted to make a comment?
Yes, I want to say that about the Roux-en-Y bypass, we should not blame the surgeons. I think the most important issues about the weight regain are about the patients. Their non-adherence, physical and mental issues, and the eating pattern. I think is the most important about weight regain rather than the surgical technique or use of circular or linear staplers, or if we use anastomosis of 2.5 to 3 centimeters. Because as I showed in my presentation, these are the most important issues about weight regain rather than the surgical technique.
Great. I mean, that's a great comment. My only kind of being devil's advocate to kind of challenge you on that. You mentioned that quite rightly, if the wider the anastomosis, then you have a higher chance of having dumping syndrome. And then that can then create a situation where the patient's grabbing sugar. And then that can give a situation where they may not do so well. So do you think there's an optimal size? I know long-term Rishi's mentioned that it doesn't really make a difference. But I think to younger surgeons watching, it's important to define, you know, what can you accept? Because even with for example, my colleagues who do a lot of MGB, they put the whole 45 stapler in the to make the gastrojudge. I mean, that they say they don't have a problem because they rely on the malabsorptive component. So for patients, for surgeons doing Roux-en-Y, do you have any comments on what you think would be an optimal size? Because it does matter to an extent, but it's important to define what you think would be acceptable.
I think it's we should implement individual approach to every patient on a robust assessment before to have the Roux-en-Y bypass, because depending on the education, understanding of the patient, compliance with the dietitian before surgery, these are very important factors. What kind of anastomosis or pouch we create for that patient? You know, because we are looking first in the 1 or 2 years after the surgery not to have any significant complications, because sometimes there are patients who have a severe dumping syndrome, or we know that 15% of the patients in UK have any problems with the motility of the esophagus, which is also very important contributing factor about the type of the surgery we want to choose for that patient. So having these multifactorial points, we have to, sometimes it's difficult to make the tailored approach about the patient. But when you go to do the surgery, we have to have in consideration all these issues before to create the weight loss surgery.
Great. Thank you so much, Ivelu, for a great overview, a great response to some very difficult questions. Very, very grateful. We're running exactly on time, which is great. And it gives me great pleasure to introduce our next speaker, Professor Andrei Kilmas. He's from the State Institute Shalimov National Institute of Surgery and Transplantation in the National Academy of Medical Science in Ukraine. And he's going to talk to us about the modern options for the treatment of esophageal cancer. Andrei.
Hello, dear colleagues. Do you see my presentation well? Yes?
Yes.
So, dear colleagues, it's a great pleasure to be invited to such outstanding webinar, and I deeply appreciate the invitation. Thank you. My report will be with the topic modern options for esophageal cancer treatment. The esophageal cancer is one of the most aggressive of all gastrointestinal malignancies. The overall 5-year survival rate ranges from the 15 to 25% worldwide, and it is the 6th leading cause of the cancer-related deaths of men. The two major histology subtypes of esophageal cancer are squamous cell carcinoma and adenocarcinoma. This slide shows us the clinical trials that are the basis of current standard treatment for locally advanced resectable esophageal squamous cell carcinoma. Here we can see two GCOC trials. The first one compared surgery alone versus surgery followed by postoperative chemotherapy using cisplatin and fluorouracil regimen, and show us better results for disease-free survival of patients who underwent postoperative chemotherapy. The second GCOC trial compared the preoperative CF chemotherapy followed by surgery versus surgery followed by postoperative CF chemotherapy for the patients with clinical stages 2 and 3 squamous cell carcinoma. This trial showed us better results in overall survival rates of the preoperative chemotherapy group. Based on this result, the neoadjuvant chemotherapy with CF regimen is the current standard of the treatment of stage 2 and 3 squamous cell carcinoma in Japan. For the patient who already underwent the surgery, postoperative CF chemotherapy is recommended for the patients with lymph node metastasis. In Western country, preoperative chemoradiation therapy is the gold standard for the patient with locally advanced resectable squamous cell carcinoma. Based on the result of the CROSS trial, which compared surgery alone with neoadjuvant chemoradiation therapy consisting of 41 gray of the radiation combined with carboplatin and paclitaxel, followed by surgery. All through the CROSS regimen provided survival benefits to the patients with both histology subtypes. The survival benefits was more evident in those with squamous cell carcinoma than with adenocarcinoma. In the neoadjuvant chemoradiation therapy with cross regimen, the complete response was seen pathologically in 49% of the patients with squamous cell carcinoma and 23% of the patients with adenocarcinoma. Several important clinical trials have demonstrated the efficacy of neoadjuvant or perioperative therapy versus surgery alone for the adenocarcinoma. The OIO trial, in which 66% of the patients had adenocarcinoma, revealed that neoadjuvant CF chemotherapy extended overall survival rates more efficiently than surgery alone. The MAGIC trial, in which 25% of the patients had adenocarcinoma, compared 3 cycles of epirubicin, cisplatin, and 5-fluorouracil ECF regimen before and after the surgery with surgery alone. The 5-year overall survival rate of the perioperative chemotherapy group versus surgery alone group were 36% versus 23%. The cross trial also demonstrated the efficacy of neoadjuvant chemoradiation therapy in patients with adenocarcinoma. But the FLOT4 trial was a randomized trial that evaluated the efficacy of the 5-fluorouracil plus leucovorin, oxaliplatin, and docetaxel as perioperative chemotherapy for locally advanced resectable adenocarcinoma. Phase 3 of the study revealed that overall survival rates was significantly better in the FLOT group than in the ECF group. If we talk about the surgery, in a short term, transhiatal esophagectomy is accompanied by less morbidity. But in the long term, the strategies can be only preferable for the patients with tumor located at the gastroesophageal junction without involved lymph nodes in the proximal compartment of the chest. For the patient with tumor located in the esophagus, the transthoracic route with extended lymphadenectomy is probably preferred because of the improving long-term survival. It was noted that transthoracic route had advantages for the patients with lymph node metastasis. Overall survival rates was 64 versus 23%. And for the patients with tumors within distal part esophagus had tendency for better survival. Although esophagectomy remains the mainstay of the treatment for esophageal cancer, it is very invasive and associated with a high incidence of morbidity and mortality. The minimally invasive esophagectomy using thoracoscopy and/or laparoscopy is being performed worldwide. As a data project shows us that more than 50% of the patients who underwent the esophagectomies were performed with minimally invasive approaches worldwide. The results of ESO data also notice that 64% of the patients who underwent esophagectomy had different complications. The National Clinical Database in Japan showed about 42% of total complications. The most frequent were pneumonia and anastomotic leaks. There were no difference for pulmonary complication, mortality rates, strictures of anastomosis, and tumor recurrence between intrathoracic and cervical anastomosis. However, cervical anastomosis provided high percentage of recurrent nerve trauma and anastomotic leaks. The meta-analysis of 57 randomized investigation with almost 16,000 of the patients with resectable esophageal cancer, which compared the complication in minimally invasive and open esophagectomy, shows that the duration of the surgery was higher in MIE group, blood loss and ICU time was less in group with minimally invasive esophagectomy, the number of removed lymph nodes was the same in both groups. But the pulmonary complication and mortality rate was lower in group in patients with minimally invasive esophagectomy. The 5-year survival rates was equal. We have performed 286 esophagectomies during the last 4 years with different types of approaches and conduits. In our days, more than half of the patients in our hospital are operating with minimally invasive approach. The total number of our complication is about 45%. If we talk about the challenging topic of anastomotic leaks, the rates of the severe complication varies from the 5 to 24% worldwide. First of all, anastomotic leakage should be administered by different endoscopic procedures. One of them is self-expanding stents. But sometimes it would be ineffective, and we can see different types of so-called stent leaks. For such a case, we have opportunity of endovac therapy, and this is very effective. Here we can see the case of endovac treatment. And now I want to demonstrate to you some short film of minimally invasive esophagectomy. So we start from the chest cavity. The patient is on a prone position. We are starting from the mediastinal dissection. Here we are using the harmonic energy device, but also we can use different types of energy from monopolar coagulation to ligation technology or others. In this case, it was the man who underwent neoadjuvant chemoradiation therapy, and we likely seen the pathological complete response. So here we can see the subcarinal lymph nodes dissection. After this dissection, we will see the left and right main bronchus. Now we can see the left and right main bronchus. After that, we are going to dissect the azygos vein. Usually here we are using different stapling device, but also you can use a hemlock clips here. We're gonna use the linear staple. And after that, we are going to dissect the upper paratracheal lymph nodes. Here we can see the mobilized esophagus with lymph nodes. Then we are going to laparoscopic approach. We start dissection from the left gastric artery. Here we can see left gastric vein and left gastric artery. The gastric vein will be clipped by regular clips, but also we can use hemlock clips here. And the left gastric artery will be divided by linear stapling device. And now we can see the dissection of the field of lymph node dissection. After that, we are going to formation of the gastric conduit. We always use linear stapling devices for this. Now we more use 3-staple technology. So the conduit is almost ready, and then we go into the cervical approach and formation of the esophageal anastomosis on the neck. So in my conclusion, neoadjuvant treatment could dramatically improve overall survival rates for the esophageal cancer. In the majority of the cases, we should use minimally invasive approach for the esophagectomies. This kind of surgery should be performed in high volume centers. Thank you very much for your attention. Thank you.
Thank you, Andrei, for an excellent, very impressive overview. This is a topic which I really am interested in. I used to do a lot of esophageal surgery 10 years ago. And I have a couple of questions for you. Now, a lot of my colleagues who are currently or used to do minimally invasive esophagectomy have moved on to doing it robotically. And because this talk is about the future, you know, what is the future in terms of esophagectomy? Because, of course, there are many surgeons in the world, including the UK, who are still doing open transthoracic esophagectomy with excellent results. And obviously, as you mentioned, a higher risk of pulmonary complications. Some have transitioned to doing minimally invasive laparoscopic esophagectomy. And certainly the work of Jim Lukatich from Pittsburgh, you know, put that as a very well-recognized approach with good outcomes. But what's your view about, first question is the robotic approach, and secondly, for surgeons who want to learn this type of surgery, whether it's a laparoscopic minimally invasive approach or robotic, what is the type of learning curve, where to get the training from? These are the questions that my trainees are asking me.
Mm-hmm. Thank you. It's good questions. First of all, if you talk about robotic surgery, this is definitely the future, I think. But the trials is ongoing now. The trials which compared the minimally invasive laparoscopic and thoracoscopic approach with the robotic surgery. So we must wait for the results. But I am concerned that the results will be equal in complications for these two groups. Definitely the robotic approach is our future, I think, and for the surgeon it's I think more easily to do robotic surgery when you are operating in minimally invasive approaches. So the answer for the next questions about the learning curve. It's a difficult question. First of all, I want to say that many courses is going with the cadaveric courses. So for the trainees, you must first of all do this cadaveric courses and trying to operate minimally invasive. In my opinion, it's like 50 operations. It will be good learning curve for the minimally invasive esophagectomy. Maybe, probably, I think they should start from the laparoscopic approach and do the open transthoracic approach. So you can do like hybrid operation. In the abdominal part, you can use the laparoscopic, it's easy. And in the thoracic cavity, you can do the open operation.
Great. Excellent comment. And I was really excited to see in the world of esophageal cancer surgery for management of leaks, you're using or considering endophac sponge therapy, something which in the bariatric world is certainly being well described for treatment of leaks to do with sleeve gastrectomy. Can you elaborate on that? What is the success of EVAC therapy for esophageal leaks, and is that the future, or are there other more clever techniques being developed?
Thank you. It's a good question. I think that first of all, we must use the stents, but when it's ineffective, we can do endovac therapy. So we must to change the sponges every 3-4 days in the anastomotic leaks, and it may probably it will take 1 month to manage the leaks with endovac therapy.
Excellent. And are there any other newer techniques being considered for management of leaks, or is it, in summary, the use of stents, EVAC? Are there any endoscopic approaches, endoscopic suturing? Does that have any role at all?
So the last opportunity that we have when we do the stents and do EVAC and it's ineffective, we can only to divide anastomosis, do the gastrostomy and esophagostomy, and then we must consider to the reconstruction surgery. Okay,
excellent. Well, thank you so much, Andrei, for a great talk. Dr. Shalan from Egypt has a question for you, Andrei.
Yes, thank you very much for this excellent presentation. But my question actually is somewhat related to my career, which is bariatric surgery, and you as an expert surgeon in esophageal cancer. Do you really practice, or do you really find that your patients among the last couple of years, 3, 4, 5 years, are coming from a bariatric source? I mean, did you ever notice that the rate of esophageal cancer, which is developed on bariatric esophagus, becoming a dilemma now, because now we cannot settle this point, and literatures are going up and down regarding how really sleeve gastrectomy can lead potentially to esophageal cancer?
Thank you very much for your question. In my practice, I didn't have such cases. But first of all, because maybe the patient with esophageal cancer has super low BMI, and but I saw the patients with malignancies of the stomach after the bariatric surgeries. So few patients after the surgeries who underwent the bariatric surgeries with gastric bypass with 1 anastomosis. I had few patients with the gastric cancer. Okay. And we must do gastrectomy for this patient.
Okay. That's a great question, that you asked. I just want to follow up on that, Andrei, just to kind of, this is a bit controversial. One of the big problems right now in the bariatric surgery world, as Dr. Shalan mentioned, is there's an issue to do with Barrett's esophagus after sleeve gastrectomy. So there's several studies, you may or may not be aware of them, looking at patients who had preoperative endoscopy showing no Barrett's, and then endoscopy 6-7 years after sleeve. These patients are asymptomatic. They've just been called for a routine endoscopy. And in some studies showing up to 19% incidence of Barrett's. And initially, when the first data came out from Alfredo Genco's group in Italy, everyone they didn't take it seriously. They thought, well, it's just one report. And then another group, Dr. Gerhard Prager from Austria, he published 10-year data showing 14% incidence of Barrett's after sleeve gastrectomy at 10 years. And then there was a multi-center study between groups in Italy and France, and by actually surgeons who were great enthusiasts of the sleeve. And that study showed up to 19% incidence of Barrett's. And so we have a big worry in the bariatric world about Barrett's after sleeve. And so patients who I do sleeve on, I say to them that you'll have not only a preoperative endoscopy, you're going to have an endoscopy at 1, 3, and 5 years because of this worry about Barrett's esophagus. It may be that the Barrett's or the reflux issue is a technical problem with how the sleeve is made, because I have many colleagues who've done surveillance endoscopy and in their sleeves, and they don't see anything near 19% incidence of Barrett's. Do you have a comment or concern? Because obviously with a sleeve, we destroy your conduit for the future. So if in 30 years' time, there's an epidemic of adenocarcinoma of the esophagus in patients who have a sleeve, you will have a big problem on your hand.
Yes, I'm totally agree with you. And I think that routine endoscopy will be performed for the patients after the sleeve gastrectomy. And if we will see the Barrett's esophagus, it can be managed by endoscopical procedures. So
there's good, effective kind of localized treatments for Barrett's, as long as the patients have surveillance endoscopy. I think that's what you're trying to say. You agree with that recommendation?
So routine endoscopical examination will help us with the Barrett's esophagus.
Great. Does any of the other expert panelists have any comments or questions? We have 3 more minutes for Andrei's talk to be over. Yeah. If you could unmute, Ivela.
Right. In my practice, I had only one case, a 30-year-old lady who had a Roux-en-Y gastric bypass in 2008 in Bulgaria. She was 148 kilos. She wanted to have children, so she lost significant weight. She had 2 children, and she approached me 6 months ago with some difficult swallow and not losing excessive weight. Unfortunately, the OGD showed advanced cancer of the lows of esophagus, and we had to put a stent. But this lady didn't have any symptoms for more than 5-6 years. Then we lost the lady, and this is the only case in my practice since 2006 with the bariatric surgery when I had a patient who developed cancer. But I don't think the issue is associated with the bariatric weight loss surgery.
Great comment. I think we all have to be vigilant, and when we follow up patients, whichever operation they've had, if they can complain of problems such as dysphagia or perhaps excessive weight loss. I've certainly had a patient who had a really too fast weight loss. Always think about other causes such as cancer. So thank you so much, Andrei, for really an excellent talk and for educating us and educating the world about the latest developments in esophageal cancer treatment. Thank you so much.
Thank you very much. Thank you.
So we're going to move on to the next talk, and it gives me a great pleasure to introduce Dr. Wael Shalan from Cairo, Egypt, a city I visited about 6 times. I always enjoy going to Egypt, and he's a consultant bariatric surgeon, and he's going to talk to us about a very important topic, a topic which, whether you like it or not, sleeve gastrectomy is a very effective operation. It's the commonest operation in the world. And he's going to talk to us about procedureless management of leak after sleeve gastrectomy. Wael.
Thank you, Dr. Harris, for this introduction. Can you see my screen now?
Yeah.
Yes.
Okay. Yes. My name is Dr. Shalan, Wael Shalan. I'm from Egypt. I'm a consultant bariatric surgery since 2009. And I work mainly in private sector hospital, very occasionally in governmental department. But all my bariatric surgeries procedures are in private section. The problem that every bariatric surgeon will face one day is actually the leak, as especially after sleeve gastrectomy. The most common complication that we find: leaks, bleedings, and stricture. But all of us are feared of leak as in the first priority. And leak in most literatures go around the figure about 1 to 3% after primary procedures, and the percentage of leak after secondary procedure or revision, redo surgery can go up to 10%. Actually, the presentation of the leak is the whole matter. When and how does it present? And unfortunately, we cannot find a typical standard presentation that you can say this is a leak or this is not. The midnight call that alerts every bariatric surgeon from his patient that makes him think of a leak is invariably the tachycardia, especially if the patient was well before that. Invariably, tachycardia would be the most consistent, if not always there, in every patient who has a leak. And tachycardia, in my practice at least, should not at all be ignored and should not taken lightly. That's why in my office I usually record the baseline heart rate in the office while the patient in the start of the interview, at the end of the interview, to omit any bias or to omit any physical exercise that causes this tachycardia of the patient. Sometimes we find patients in the office with a heart rate of around 105, 110 while she's relaxed, probably due to the obesity itself. So if this patient would call you at the night after a week or two from the surgery telling you my heart rate is 115, you wouldn't go alert. In my practice of over 1,800 patients of sleeve gastrectomies, I can tell everybody that left shoulder pain in a patient who have been well before that is very alerting sign. Yes, we all encounter left shoulder pain in the first few days after surgery because of the splenic pole infarction, because some left subdiaphragmatic collections of blood or whatsoever. But in a patient who have been well for 10 days and then he starts to have left shoulder pain, this should be very alerting sign. In my practice, I have seen 2 patients of fresh hematemesis that presented to the hospital with a fresh hematemesis and even shock, and that was the only presentation of acute leak. Other signs invariably include fever, abdominal pain whatsoever, vomiting, and these are also, the matter of fact is that classification of leak is not always standard. Many people will go to classify the leak according to the time of the onset, the clinical presentation, the site of the leak, the width of the defect, the extent of the peritonites, and mixed factors. And I do believe more in the last one, which is the mixed factors. You cannot actually put a leak according to only one classification. How would you manage the leak becomes the question nowadays after the sleeve gastrectomy become very popular, how to manage the leak. This is multimodal, and it would need the multidisciplinary team, not only the surgeon, as every one of us know. And the treatment should be based on the timing of the presentation, the extent of the peritonites, the status of the malnutrition, the size and the site of the leak, if there is a stricture or not. Invariably, every literature would agree with that enteral feeding would facilitate the healing, while distal obstruction is the only independent factor that will hamper the healing and increase the morbidity and even the mortality. So in some cases of leakage, there is less urge to perform extensive surgical interventions. And sometimes, many times, I would tell my assistants and my colleagues, sometimes in order to prevent morbidity of the leakage, you can harm the patient. And if you go for more aggressive surgery, more aggressive invasive procedures to trying to treat a leak that would otherwise heal in its own, so why not? Why don't you just watch, wait and see? The new endoscopic era of interventional radiologies and endoscopic modalities like the EVAC, the double pigtail, the stents, the clips, all are still much better than going into more aggressive surgery. Among those popping up, the procedureless management or the conservative management, the non-interventional management of a leak is very important, although when I searched in the literatures, in the published data, there are not many who talk about it or who advise with this. But in this little humble case presentation, I wouldn't say this is actually a talk. I'm just sharing my own experience with you in 5 cases among the period from 2020 to 2021 that I managed successfully. We managed 5 patients with acute leak without intervention. So the question of the procedureless management, it can compose of any of the following or any of a combination. Aggressive antibiotics, this is the first line of treatment for sure. In my practice, I always used amikacin or one of the aminoglycosides at least in the first 4 to 5 days. And believe me, as far as this drug is very cheap, and many of us would really fear using the gentamicin or amikacin for the ototoxicity and nephrotoxicity. I've never seen any of those. I just read about them in the books, but it actually works very well. PPI, proton pump inhibitors, the patient should be fully controlled with proton pump inhibitor, either in a BID basis or an infusion pump. I use prokinetics to facilitate the emptying of the stomach. And now the question of, would you keep the patient on TPN or an enteral feeding or NPO all the time? No, actually, I kept all my patients on NPO with the IV fluids for 4 to 5 days. And then, according to the situation, I allowed clear fluids to start. And following this with the ultrasound and with the laboratory endesis. Symptomatic treatment for sure. And the most important, if you apply the procedureless management of acute leak, you should closely follow the patient by both laboratory indices like the TLC, the CRP, procalcitonin, the vital signs, and you should always at least do once or twice sonography to detect any changes in the size of the collection. Usually we had a baseline CT volumetry, 3D gastric volumetry, as I will show you in the next slides. And usually we obtain a second one in 2 to 3 weeks if everything is going well and the patient is progressing. We are always ready to abort this procedure if the patient is not responding, if things are not getting well, if the size of the collection radiologically or by the ultrasound is not decreasing or is stationary for longer than 10 days, we shift to more invasive surgery. The question of the procedureless management or non-interventional management is the who and when to apply and not what is it. Everybody of us knows how to treat an intra-abdominal sepsis, but when and to which patient you would apply this. In selecting the who and when, we have to think about 2 factors, the leak and the patient. Leak should be the one that resolves spontaneously, should be either contained leak or sealed leak, should not be a generalized peritonitis. The leak should reside in a subclinical manner. It should not be applied if the patient is in sepsis or in a septic shock. The patient should be hemodynamically stable, and both leak and the patient should show at least improvement in the first 48 hours when you apply such a wait-and-see management and after you start the antibiotics. The sonographic and laboratory indices are getting better. You should not continue in such management if the TLC is not responding or the procalcitonin is getting higher or the CRP is getting higher. This is very important also. The patient should be, if not in the hospital, should be residing in a location where you can get him into the hospital in no more than 1 hour. and the patient should be understanding fully the technique that you're following, and he is agreeing with this, and he is also consenting about an urgent shift to a more invasive treatment if it ever calls for. Because prolongation of this method might lead to creation of more and more complicated chronic leak that will need more complicated surgery. My first patient was a 30-year-old male with a BMI of around 46%, no associated comorbidity whatsoever. The procedure was a smooth and eventful discharge in the next day, and they started to tolerate clear fluids, and he started to complain of a left shoulder pain with a tachycardia on the 11th day. At once, we obtained his laboratory indices. His pulse rate was 110, his CRP was 224, TLC 19.5, temperature was 38. So I sent him for the 3D volumetry, and these are, that was the initial, let me just change. Okay, this is the initial CT findings, where you can find the leak site is about 3 to 4 centimeters from the gastroesophageal junction. This is the usual site. Defect was around 6 to 8 millimeter wide. In my opinion, the defect size, the size of the defect, the diameter of the defect is very important when you consider the management, because if it's very small diameter, which is less than 2 to 3 millimeter, which is the size of the double pigtail catheter, then unfortunately you would success to manage this treatment, because the collection will not actually evacuate into the stomach. But if the size of the defect is larger than the bore of the catheter of the internal of the double pigtail, so then there is a chance to success. Here it's about 6 to 8 millimeter, and the perigastric collection was all very well walled off, and the leak was totally contained, about 80 to 100 cc with few air foci inside it. But there was no holdup of the dye or of the contrast. There was no distal obstruction, and there was no free fluid in the intraperitoneal cavity. So we started to apply the procedureless management with all those lines, and in 14 days, the patient, for sure, in the first 48 hours, the pulse rate went down, temperature down, pain is much better, and we followed the COP every 1 week. In 2 weeks, we had these results, magnificent results. The CRP went to 12, pulse rate 79, TLC was only 8, patient is tolerating free fluids, and then we had the CT complete resolution. Actually, we had the first initial ultrasound with complete resolution of the collection, and then we had the CT confirmed complete resolution. This patient now is 9 months after the treatment, and he's doing very well. My second patient actually is 26 years old male with a BMI of 53. He went into a very smooth operation, but on the next day, he had acute bleeding, for which he was re-explored, received 4 units of packet RBCs. He stayed in the hospital for 3 days. We could not find the source of bleeding in the second look surgery as it's usual, but he went very well. And then he started to complain of left shoulder pain on the 39th day. Pain is increasing and not relieved by simple analgesics, and it's getting worse when he lay flat down. There was no any other complaint, and he said, it's not really troublesome for me. It's not really bad pain. I can tolerate this. But because I have very high suspicion, so I sent him to obtain this CT findings, where the defect is around 5 millimeter. It's around the mid body of the stomach. Now it's not into the related to the gastroesophageal junction. And this what makes me think that that was the initial thing was a collected hematoma, infected, and then eroded into the staple line. Collection about 20 to 50 cc, and I had a call from the radiologist to tell me that the tissues around the collection is very thick and dense. He wanted to tell me that you don't have to rush to any invasive procedure, because he thought that this kind of collection would actually respond to management, to conservative management. And this is the 3T after 14 days or probably 16 days. All his indices went very well, and he responded very well, and the collection resolved spontaneously. No retraces. My third patient was referred to me from another, he had his surgery 30 days before he comes to me. And I don't know actually what happened inside the surgery that made his doctor, as you see, left the drain for 30 days, and he didn't take it from the second day. I don't know why. According to the story of the patient himself, that the drain was discharging blood, then discharging serous fluid, then sometimes the output is related to the color of his oral intake. So we had again the CT volumetry with the leak site was about in the mid-body with a free passage, no hold up, and this is very important. There is no hold up, there is no delayed emptying of the stomach, there is no stricture, there is no kink distal to the leak site, or otherwise we cannot apply such management. Here the defect size was only 3 millimeter, and it's very small, with a collection about 150 to 200 cc, while the patient was actually well, he was not in sepsis. So what we have done here in this patient, I sent him to do an Egd upper endoscopy because the defect size was very small. And actually the site and the size of the leak were confirmed by the endoscopist, but unfortunately, I don't have pictures or videos for the endoscopy. So we started in a conservative management for 4 days. Then we went to upper endoscopy. When he catheterized the defect and injected some dye, he found that the dye came out into the drain. And this, thanks for him that he did not continue to put the double pigtail, otherwise it will change into a fistula. So he took it out, and we managed to continue on the conservative management. And as you see, the patient in 6 days normalized his total leukocytic count, his pulse rate down to 80 to 85, CRP is decreasing, and we followed up every 2nd or 3 days the collection size, and it's becoming much better. This patient was heavy smoker, and he did not even stop smoking. He started to smoke 5 hours after full recovery from his primary procedure. And these are the CT films in 22 days. Patient is totally normal, and this patient is almost now 3 months after these films are obtained, and he's doing very well, obtaining the now in solid food. My 4th patient was a 39 BMI 39, and she's 29 years old, female, and again an eventful procedure. Probably most of us know for sure that the uneventful, simple, straightforward procedures are those who are amenable for complications. This patient presented with a left shoulder pain, no other complication on the 9th day. Pain, again, reported as very mild at the start, increasing over next few hours, getting worse by lying flat or by deep inspiration. Tachycardia followed in few hours. The patient, when started to complain of shoulder pain, she doesn't have tachycardia, no fever. By the time I sent her to do the CT, while she is in the CT, then she called me and she said she started to have tachycardia. She got the pulse oximeter, and her pulse rate was around 120. And as you see, most of the indices are getting high. And this is the CT. Again, the leakage is about 2 to 3 centimeters from the gastroesophageal junction, and the defect is around 8 millimeter wide with 100 to 120 cc collection. There are some traces of encysted fluid and air around the perisplenic area, but the patient actually did very well once we started the management. In 48 days, she became pain-free, and she started to normalize her temperature and her pulse rate. After 18 days, actually, when I send the patient back to the CT department, only when the sonography tells me that there is no more collection. because if you get CT every couple of days, then you wouldn't have enough time to tell if you're improving or not. Last patient was 41 years old with a BMI 44, and he's diabetic, and he had history of gastric balloon removed. Actually, when he came to my office, the balloon was removed just 1 month, and then I sent him back. And usually I don't operate unless 3 to 6 months after removal of gastric balloon. This was a lengthy procedure, lots of adhesions, lots of posterior adhesion in the stomach. The gastric wall was very thick, so we went for black reloads all over. Smooth recovery. And then after 10 days, he called me at the midnight telling me that he had only 1 attack of high fever and left shoulder pain. And again, these are the indices. CRP is high, pulse rate is high, temperature is high. And this is the CT we had. You see, this is a huge collection, about 210 cc. And the defect again is 2 to 3 centimeter from the junction with a 15 to 17 millimeter wide defect. I think this could be a failure of a part of a reload. It's not only a defect. But fortunately, the patient on the next day, he's not telling me that he has any more pain, and he feels better and he feels well, although we did not even touch him yet. So this encouraged me to start, although the collection size is big and huge. So what if we start for 48 hours while we are keeping an eye on the patient? And that's what happened. We started. This is another X-ray where they chose the contained leak and the defect size. Very beautiful 3D volumetry, actually. It's very beautiful and very conclusive. And these are the after 19th day, we had these films. The total resolution of the leakage, total resolution, healing of the leakage, and total resolution of the collection with normalization of all the indices. And the patient actually, this patient now is 5 months or 6 months after these films, and he lost almost 60% of his excess body weight, and he's doing very well, thanks God. So what is the home message? Leak is very dreadful. Yes, it's very rare, but it's always there around the corner. You should have a very high degree of suspicion to diagnose the leak. Tachycardia and, in my practice, left shoulder pain, very alerting signs that should not ever taken lightly. And the procedureless management in a contained leak of otherwise stable patients should be tailored to every patient and should be assessed every day. It should not be a decision. It's not a long-term decision. It is a decision of 24 hours. And in the next 24 hours, you should have in mind more to do. The collection size and the collection site should be tailored to very important another factor, which is the width of the defect, to anticipate if you need to go for endoscopy or if you leave this collection to drain spontaneously because the defect is wide enough. And the procedureless management should always be in hand and should always go side by side with other more invasive procedures. Thank you very much.
Thank you very much, Dr. Shalan. That was really a very impressive talk. And thank you for sharing your cases. It's very, very honest of you to share these cases, which we all learn from. So I have a couple of questions. The procedureless management is absolutely a very sound way to approach a patient with a leak. I wanted to ask you, it's perhaps a difficult question. How many patients have you used procedureless management on for a leak where it hasn't worked?
Where it hasn't worked?
Yeah.
No one.
Where you've had to move on.
Actually, I did not initiate the procedureless management unless only on those 5 patients. I had more leaks that actually it's not suitable to start with, like one with peritonitis, one with a patient is hemodynamically unstable, the other one where the leak is not contained. So no patient went into procedureless management and then converted to invasive procedure. Not yet so far.
Great, excellent. So my second question then is, I noticed from your cases that most of the leaks seem to happen 2 to 3 centimeters below the GOJ. Is that correct?
Yes.
So what do you think the etiology of that is? Because a lot of us, when we started doing sleeves, we were very paranoid about the angle of His. And then after a while, we were told not to go too close to the incisura. So now we keep that area wide. So in your cases, you didn't have any issue with the incisura. You didn't have any issue with the angle of His. So what do you think the etiology is in your case?
Well, I think the most independent factor is to leave the incisura very widely open, at least to avoid the leakage, and in case if you have leakage, then to facilitate the healing. One of the most important things is not to dissect much into the posterior of the fundus in the area where you leave intact the phrenoesophageal membrane the best you can. Do not go through the angle of His. Do not expose the left crust totally. Some of my colleagues like to expose it all the way down until they see the V. I think if there is no posterior sag of the fundus, if you can get the fundus all the way up, there is no point to dissect the left crust. There is no point to cut all the blood supply of the beyond the needed one just to perform a sound sleeve gastrectomy. The second thing, that whatever you do, I think sleeve one day will bite you.
I agree with you. I think if you do enough, you're going to have this problem. It's a matter of time. But thankfully, the incidence, as you mentioned, is very, very low compared to 10, 15 years ago. So one more question with respect to, from what I was interpreting from your answer to the last question, is it perhaps vascularity has something to do with these leaks. Do you consider, I was really so impressed to see that you, in your hospital, you have easy access to CT volumetry, because I think that's going to be the future of management of a lot of these revision cases after sleeve, as well as complications. Do you have access to ICG, indocyanine green, as a way to assess perfusion to your sleeve? Do you see that that would be of any use to you for doing sleeve gastrectomy, given the fact that this is not this seems perhaps either a staple cartridge issue or a vascularity issue?
Well, in my hospital, I don't think we have the access to this first. But I think, as you said, right, the whole thing of leak, or at least part of the leak etiology, is related to the vascularity, the native vascularity of the stomach itself, or the vascularity after the dissection. Some of it will be related to the thermal injuries during, and I had one patient of this thermal injury during the dissection. The question comes, if I have this, and if we come to know that the vascularity of this stomach is not proper, or the vascularity in the fundus itself is not very well, so would this make you stop doing the sleeve?
No, but it may make you a bit more, it may kind of guide you in terms of flagging this patient up perhaps for a higher risk of having a problem.
Yeah.
And maybe you might be a bit more conservative with their diet post-op. You might watch them a bit more closely. You may, I'm not sure if you're using buttressing or over-sewing, you may decide to imbricate the staple line. So it may help you as to what you do post-operatively. Any comments, Dr. Velo?
I think that the ICG will be the standard for sleeve gastrectomy in the next few years in terms of prevention of the leakage about the blood supply. And there were several presentations and videos that the use of ICG is very helpful and powerful too, in order to prevent the possibility for leak after sleeve gastrectomy due to some problems with the blood supply. And also in terms of the Ivory Lewis, the ICG is very helpful and powerful about the lymph node dissection. So I think this is the standard in the next few years.
Any comments, Rishi, about etiology of vascular kind of etiology for leaks after sleeve? Have you seen any such cases where there's no narrowing at the incisura, haven't gone close to the angle of His, but still had a leak?
Right. Sleeve leaks are very uncommon now, Harris. I must have done around 2,000 sleeves now, and looking at my overall healthy weight data, I think we've done 8,000 sleeves. Sleeve leaks are rare. So firstly, it is very difficult to generalize a common etiology as a result, because nobody has experience of why they are happening. I think it is most of it is mechanical or a problem at the time of surgery. I think this is just my impression. So either a narrowing causing a leak proximally, or misfire of the staple that goes unrecognized, or a tear of the proximal half of the sleeve. Because if it was vascular, something so common, which is, I used to do esophagectomies until last year, and I've had conduit necrosis, I've had leaks. It's a common etiology. It happens to all surgeons. But I just don't see leaks anymore that commonly. So I think it's all mechanical. It's not vascular. If it was vascular, you and I would be having a constant fixed percentage of leaks, which we don't. We should all be having 1 to 2%. Instead, you tend to see sporadic leaks in experienced surgeons and slightly higher risk of leaks in inexperienced surgeons. It points to a mechanical theory behind leaks rather than a vascular theory, but that's my personal feeling.
Okay. Any comments, Dr. Shalan?
Well, I myself had about 1,800 cases. I got around 8 patients of leak over 7 years or 6 years. 4 of them, I had imbricated the stable line, and 4 of them were not. No, wait a minute. 5 was imbricated stable line, and 3 with no imbrication of stable line. So I would raise the question: would you ever think that imbrication of the stable line would work to protect against sleeve? I would say no. I've seen the defect bridged with myproline, and still the defect is there. The incisura was quite wide and open, and there was no any, I wouldn't say mistake, but I mean the procedure was quite well. There is no thermal injury. It's not narrow. It's not twisted, and there was a defect. So I don't know what's the etiology of leakage. You said right, Dr. Rishi, you said right. Many of the factors that can occur intraoperatively can conclude into leakage, but even if you do everything in a standard way, still leakage is there, is always around the corner. And I consider every sleeve patient is a potential leakage until he passes the first 3 to 4 weeks at least, because actually you cut through the wall and you just put synthetic material there just to hold it together. So who would win, the synthetic material or the nature of the content inside that's trying to go through any defect there? That's my conclusion.
When you say that, Dr. Shalan, I think I remember one case, and this may shed a bit more light. This was a patient post-splenectomy I did a sleeve on, who was on methotrexate for rheumatoid arthritis and developed a deep ulcer. I called it a deep ulcer, but I think it was a self-contained leak, which settled after dilatation of that area. So again, yes, there was a problem because patient had a previous splenectomy, but there were drugs. So I think you and I, and I think all of us are right that it is multifactorial. It's probably not just mechanical, not just vascular, not just medications, not just bad luck. I think it is a number of factors, and because the incidence is so low, none of us are able to decide why it is happening. I mean, for esophagectomies, although we do only 20 esophagectomies a year, as opposed to 500 sleeves a year, I know why leaks in esophagectomies happen, despite only doing 20. And despite doing 500 sleeves a year, I still don't know why sleeve leaks happen. So that is how rare it is. And that's the nature of the beast, I guess.
Excellent. Well, I'm afraid that we are out of time. I'd like to thank all the panelists, Dr. Singhal, Dr. Shalan, Dr. Zvetkov, and Professor Kilmas for taking part in this extraordinary event. Very grateful to Ezisurg as well. And I'd like to hand it to Josie from Ezisurg to close this 10th Ezisurg webinar, which has been a tremendous success and highly educational.
Okay. Thank you everyone to join this webinar. It's a huge honor for us to have this international group of experienced and well-known surgeon with us. You're the reason why people all over the world are watching and learning from this webinar. It's also our pleasure to provide a platform where you can discuss the most recent and most important topics in the bariatric field. Last but not the least, we wish you all have a great and fantastic Thursday. Thank you.
Thank you very much.
Thank you.
Thank you all.
Thank you very much.
Thanks. Bye-bye.
Thank you.
Bye-bye. Thank you.
Bye.
Bye-bye. Thank you.